Hello, this is case discussion to talk about challenging cases. I am Kim Se-jing. I'm going to facilitate this session. Today, to solve your problems, we have three masters with us, Dr. Kim Kyoung-won, Kim Yeong-taek, and Park Jong-won. Hello. So let's see what we are going to discuss this session. 65 years old male suffering from depression and actually extracted number 16 7 months ago. And the issue by the doctor is that want to place implant in number 16, but it has a wide width. So I was thinking of using SS or TS implants, and if I use SS, can it compensate the wide width? And if I do sinus elevation, can I secure long-term stability? Now, what do you think of this case? Actually, as you ask, I would go for SS because I really love SS implant as dentist. So if there was only one implant to use on earth, and that was dictated by law, although SS has its own limitation. If that law is, set by the government, I would just use SS. So you think SS is beneficial? I just like that implant. What about you? Actually, I'm opposite of Dr. Park's opinion. If there was only SS, I might not do implant anymore. Then what about you? I think you need TS. I agree. As a surgeon, of course, some use SS because prosthesis reasons, but you sometimes have to do GBR, and there's cover screw, and if the tissue level, you can cover it. But there are challenges with SS, so I would go with the TS. So I do understand the challenge. It's very wide width, so you might lean toward SS, but I would share my reasons why I would go with the TS. And sinus, I think it will be okay, but I will give you opinion a bit later on. Actually, I also use a lot of TS, and also for single implant, I also go for SS at Dr. Ba. Prosthodontics, do have also that opinion. But anyway, TS and S do have their own benefits and weakness. So for this case, the long-term prognosis for sinus, as you know, it's not going to be a problem. Residual bone height is also okay. But I believe rather than sinus floor level, the alveolar bone a bit being low, if I have to do GBR, I think you have to use TS, as Dr. Kim has said. But if you don't opt for GBR, then maybe going with SS will be also good. Anyways, on the upper side or number 6, if it's single missing on the panorama, there are cases you think it's really wide, and maybe this dentist also sent in this as an issue. So 12 millimeter, it's sometimes confusing whether it's really wide. I don't know. So doctors watching this program, think about what your approach would be, and if you want to share opinion, please use the chat box. Now, Dr. Kim Kyoung-won, please go first. Actually, I searched for a similar case, and in case of this patient, it's before extraction 2019, and after extraction December of the same year, number 6 is missing here. So for this patient also, maybe it's also 12 millimeters. So for me, as Dr. Park has said, for this case, actually, crustally, I did a bit of bone grafting, but I think it was very minimal. So residual bone height was, quite okay. So in the extraction socket, wide platform SS implant, I used that. So I think implant width was about 4.5 or 5.5. It was wide platform type. So after 1 year, after prosthesis, prosthesis, I didn't put that in. But anyway, I don't know about the abutment margin there. Anyways, for this patient, after that, on the other side, it was the same problem. So I looked at it. So 1 year ago, prosthesis, the SS, you see the upper part is elevated, and the other side, it was about 12 millimeter. I measured it. And so I placed it and looked at the relation with the opposing teeth, and again, same as the wide platform of SS. So for this patient, as you can see, about a year ago in December 2019, we did the immediate placement, and as post-OP, we put in SS, and in the follow-up time, the opposite side, number 6, was kind of problem, so we placed the same implant there also. So I think it's very similar to the case that was, posted by the dentist. So TS might be an option if you think of GBR, but if not, I think SS could also be an option. I have a question. Actually, my generation, when I started with the implant, we had a lot of Korean-made implants coming out, and the trend at the time was the TS type. But before that, I think you place a lot of external types, right? But before even you, when I think at that time you probably use a lot of external types. Yes, from early 1990s, from 93, 94, after I finished my military service, I started to place implant. At the time we only had external type. There was Brandon mark, but it has a limitation. But other copies of Brandon mark, I used it a lot. So 3i and other foreign made, I used that first. But by late 1990s, with the financial crisis, I started to use Korean-made implant. At that time, I used a lot of external type, and then Straumann ITI tissue level came in, and with the external, I used with the tissue level together, and after that TS3 or Astra type, that type of internal hex. There was no marginal bone, so we started using that too. But for me, actually, external I used at the time, but no longer. I mean, some still prefer external, but for me as a surgeon, I believe external is not really preferred. So since the TS implant was introduced, even then, sometimes I also opted for tissue level implant. But Straumann, when it was good as a tissue level, I placed it on the anterior side, but prosthetist really criticized me. You should not place it on the front side. So I should have thought more. But since then, and more recently, TS type is the one that I prefer the most, and sometimes when I need, I also use tissue level. Listening to these two, I find that what I said in the beginning should be edited out. Well, actually, what I want to ask is that US type is now available. So have you really used US type? Because if you have a lot of width, in terms of anti-rotation, it's more favorable. I actually used that in the past, US type. But even now, there are some that prefer US types, and most are prosthetist, because external type US type, it's challenging in the prosthesis, but there's more options of the prosthesis you can choose from. That's what I heard. So those that prefer external types are, prosthodontists mostly, I believe. So for this case, I used SS. So I actually found similar case. It was a fractured case, but in this patient, there is the number 16 mixing, but the implant already there. It was TS type. It was not OSSTEM's implant, but another company's implant. But I think diameter was about 4 millimeters. So we placed a single in number 16, but the missing part might not be as wide as 12 millimeter, but it was quite large. So, it was quite used well for 6 years, but still there was a marginal bone loss, and maybe because there was no GBR in the beginning, but there's a marginal bone loss, but still retained. And then there was a few times of screw fractures in between. And, this was before the patient came to me, but after 8 or 9 years, the thought the screw got loose, but if you look at it, the upper part was not there anymore. So implant itself was actually broken. So the patient then came to me. If you look at the CT, you used for 9 years quite well, but what remains as an implant is leaning more toward the buccal side. So the initial positioning was a bit long. There was a bit of buccal palatal side cantilever. So removing them, and the wanted immediate placement of another implant. But if you have like the top missing like that, then EFR kit, fixture removal kit, could not even be used. So when it came to me, it referred to me, the gingiva was quite healed after breakage, but I opened the flap and I could only remove what's left with the trapping. The loading was there for 10 years, so I removed the trapping, and buccal plate was very thin like paper. But as you saw on the CT side, there was a bit room on the palatal side, so I removed the broken implant, and it was really sharp, had the sharp edge. So on the palatal side, with the side cutting bar, I created a path and placed a TS type 5 millimeter diameter was placed, and then on the buccal side, the exposed area. First of all, at contact with the fixture, I used allografting, and on the outside for the retention, on the crestal side, there was a bit of marginal bone that had disappeared, and I used the xenograft there and placed 2 collagen membranes and then sutured. And as you can see here, the fractured implant was removed, and then immediately on the palatal side, if you look at the post-op photo, TS type implant 5.0 diameter was placed, so the retention with the GB on the buccal side. So it's a similar case, but for this case, to do GBR, as Dr. Yeong-taek said, using TS type of implant might be better, because if you use SS here, it would be hard to do GBR. Actually, transmucosal GBR is not something I do often. So that's how I resolved this. So for broken implant, rather than broken because of a TS type, on the single, the posterior side, it's hard to be retained if it's a single implant. So that's what I think. In my opinion, the bone resorption height photo showed that because of hex of the implant, because it becomes thin, and that's how it got broken. And maybe it was 4 millimeter also. So because of all these reasons, it broke. So Dr. Park, you think it would have not broken if it was non-hex? Yeah, right? Well, that's just hypothesis. And anyways, then Dr. Kim Yeong-taek. Actually, I didn't prepare a case today. It's a single implant, so I did a lot of these, and as a case, there were not many photos that I taking, a lot of radiograph, but that's meaningless. So for this case, actually focus on that, what was posted by that dentist. So this is the case photo. The residual bone is 5 millimeter, and the crown and abutment. So crown itself plus abutment height is 12 millimeter, and with the transmucosal, you can reduce that. And if you use TS type implant, use bone level, then 12 millimeters will be all crown, and the mesiodistal width is 12 millimeter. It doesn't look that deep here, but if you look what I've drawn, number 7 on the mesial side, there is a bit of a penetration. The prosthesis margin was not that good, so probably polishing or creating new crown would be necessary. So 12 millimeter, or it could be a bit more than that. That is the situation. Actually, if you look at it, it's really wide. If you see the form of tooth, I think dentists have good gut sense. So if they say it's wide, it's really wide. So I think that's how the dentist had posed this issue also thought about this. So let me explain. There was a question about sinus elevation. Actually, on the crestal placed implant with OSSTEM, sinus floor elevation, placing more than 2 and doing elevation. That was the initial technique as introduced by Somerset. But then in 2003, in another literature, and also in other literatures, single platform with the sinus approach can be very stable. So as you say, 92.7% of success rate. And because of that good success rate, single sinus elevation is not such a problem. And the bone potential in the sinus is really good. So they're even saying bone grafting is not necessary, and you can use any material. So single sinus elevation, no problem. You don't have to worry about that. And you can elevate more with the GBR. But if the sinus with the stable bones, success rate would not go down. So using sinus more would be better approach. So again, sinus no problem, elevation no problem. But if you do sinus elevation, you go a bit deeper. So the crown height is 12, then it might be not 2 to 1, but 1.8 to 1. So there is a big difference. In that case, then this is the slide I also used in another lecture. Up to 2.1, many say it's no problem, but it's not even 2 to 1, so I don't think it's an issue. So crown implant ratio there's no problem. Sinus side, as I said, no problem. But the issue is whether to do bone level or tissue level. It's something that you really have to think a lot about. Is it SS or TS? Or you could even think about US type. Patient might want that, but patients are not so familiar with the implant system. So usually it's a dentist that have to make the choice. And a lot of literature shows, this is 2012 literature, and it says that looking at the stress distribution, TS implant, the bone level implant is better. And on the bone level side, stress distribution is much better, so there's no marginal bone loss. So compared to tissue level, bone level is more favorable in terms of results. But there is a limitation in this literature. It's been a while ago, and it is a finite element analysis, and for each material, you have to designate on the computer. So you analyze the canthallus and cortical bone, and with cortical bone, there's a lot of more stress, so it's better to use bone level. With the 30-degree angle, there's more stress distribution. That's what they said. But there's also literature that says the opposite. It's from 2020 in different angles. TS versus SS. So bone level versus tissue level. Tissue level, there is more stress distribution. So bone level implant has more stress. So it's the opposite conclusion from what we have seen before. So there's a lot of different conclusion. This had a lot of better finite element analysis. So it might be, this might be the better answer, given also this is most recent paper. But if you also see the meta-analysis literature, as you can see from this table, Now, it's not meaningful difference, 0.06, but on the bone level side, it's slightly more favorable. The marginal bone loss is a bit lower compared to tissue level. This is because if it's bone level, then the bone level implant is Company S and Company A, very well-known ones, but mostly the bones secrete more than the initial level, so the days are much good. So if the tissue level is wide, SS you think would be better, but on a long-term result, the bone level, in terms of bone level type, in terms of marginal bone loss, I think could deliver better results. So bone level implant, because of, they say, micro thread, you have such a result. But anyway, in my opinion, not tissue level, but also bone level would be okay. The wide width, you don't have to worry that much about. But another consideration is that when you place implant, if it's wide, then if you place in center, it will be okay. But there is a possibility of being off-center. So there's who really researched on that. So they looked at from 4 years to 10 years, and there's not much difference between centered and off-centered. Of course, this is from biological side in terms of bone loss, but prosthesis complications, there could be more. It's not had that detailed analysis on that side. I also researched on that. This is for the single case, and for the mesial cantilever, how much does it create a problem? In what level? If you put it on the back side, number 6 or 7, then going toward the back might be better, because if you come too close, you can come into contact with the teeth. So if it's too wide, there could be screw fracture. If it's too close, you can come into contact to the tooth. There could be chipping, other complication. But actual studies show that success group was 3.1 in terms of the distance. So 3.8 had a complication. So there's a meaningful difference. So the longer distance could be more complications, and 3.7 on gives you problems. But below that, if it's single case, there's not much of a mechanical problems. So this is our case. So I think what dental this posted, it's 12 millimeters of the width. So number 6, you place 3.5 or 5 millimeter. I would go with the 5 implant. Then what remains 7 millimeters. So it's 3.5 on both sides. So I think 3.5 in terms of cantilever, it would not have much impact. Hence, I think you can place without much troubles. So if you place TS, you go more toward the inside, and crown might be elongated. But if you see how it's placed with the sinus elevation, the crown is not that big. So I think it's no problem. And with the SS implant, crown might look better. So I don't know. If you think about emergent profile, TS might be more favorable, but I like TS better because I think most surgeons would agree with me. So that's the case. So in conclusion, transcrestal sinus floor elevation, as I also said in another lecture, it's more challenging to do, but it takes less time. So it's a bit tough to do, but it's more comfortable for the patient, and long-term stability, I believe, is really good. And TS, SS, both are okay. That's what data said. But I personally prefer TS, and for surgery and GBR, as Dr. Kim has said, in case of surgery, you can switch very easily. So that's why I prefer TS. But if it's too long, then now 12, you said, is kind of in between. But if it's longer than that, you could place 2, then you need at least 15 millimeters. So if not, it's close to 12, like 13 or so, then with the SS type, going more wide might be better. So I also did a few of my cases because the prosthodontist asked me to in that way. But if you cannot gain primary stability, TS type might be more favorable. Yes, thank you very much. Thank you for that. Lastly, Dr. Park. Yes, what I said in the opening, I need to, be careful because I want to correct myself. But what I want to say in the beginning is to express how much I like SS implant. Saying so forcefully that if it's set by law, maybe that was too much. But anyways, in the clinic, I believe roughly I use about 30% SS and 70% TS. It's inevitable because TS is more favorable in some cases, but I personally like SS and I try to express that, so I hope that you will not misunderstand. But anyways, so why do I like SS so much? First, it's about structure durability to reduce fracture. When it comes to fracture, there are so many reasons. Like there are different reasons. It's about distributing the biting force and what kind of material was used for the implant, and also patient habit also plays an important role. And how did you put the prosthesis, and also wall thickness is also important. So there is a lot of different things involved, so you cannot pinpoint to one reason, except I think most agree that for TS type, on the cervical side, the stress is concentrated, whereas for SS, for the external type, vertically, the biting force is loaded. Hence, compared to cervical stress, with the fracture, with a new fracture, maybe TS is a bit on an unfavorable position. But that does not mean that SS never breaks. That's not it. Actually, TS and SX, when it comes to fracture, I do not believe there is such a big difference, except maybe SS is a bit slightly better. I just have that assumption. I think that is right. There could be tearing for TS, but for SS and US, there could be no tearing. Yes, fixture tearing. I think recently on the posterior side, you put in more thick implants. So recently for premolar 4.5 and for molar at least 4.5 or 5.5, I placed them. So maybe I'm correcting myself very well. So I'll try my best to give more explanation on what I said in the opening. I had 2 times of breakage of fixture in my clinic, so I prefer now more TS because the non-hex fixture is now available. Non-hex implant is available, so the lateral wall has become thicker, and the vertical fracture has now, I hope, will become less. But so fracture about that is just assumptions. I don't really have any base. But just looking at the thickness with the 4.0 diameter, TS is, yes, true, it's the thinnest. So on the posterior 4.0, I don't place them, but inevitably I have cases where I had to place 4.0s in the posterior side. So let's look at the actual case. It's I don't know what led to fracture because it happened at another clinic, but just looking at the conclusion, there was a fracture, and looking at that, it's a screw type implant. And if it's screw type, I don't really prefer that. If it's single, then it's okay, but multiple splitted screw type, there is a high possibility of misfit. And for internal conical type, there is no room. Joint stability is, yes, very strong, but there is no room for making error. So for screw type sprinting like this, could put a lot of more force. So there was a breakage. The screw type, it's a cement type's screw. Yes, 2 splinted prosthesis. So if it's placed like that, then prosthesis not to break, then what would be better than screw type? Cement type? Yes, cement type or ER type. ER type without cantilever, 3.5 diameter, I think might be okay. So I actually do not like cantilever, and splint screw time, I don't really like that as a dentist. And I hope there will be more chance to talk about it later on. But anyway, I removed fixture and then waited. And the SS fixture, the one that I like best, I placed it. And when I place SS type, if there's no particular reason, I only go up to 4.5 diameter. With TS, I also use 5 millimeter a lot, but for SS 5.0, I don't use them a lot. Of course, in the maxillary sinus, if there is a lot of bone width, then 5.0 I sometimes use. So it's a wide neck, right? Then wide neck 5.0, 4.5. On the top part, it's the same. Yes, top is the same, only the bottom is different. And 5.0, I always use that as a rescue. So I finished final prosthesis and there was two implants and used for 9 years. So I think patients has not think to really complain, but but patient also had complaint. It was very uncomfortable 9 years, and he said there were other complications. There were gingivitis and tried to clean many times, and it was not good 9 years, he said, the patient did. But after placing SS and with the single implant, it's very easy to retain and maintain, and he thought it was very easy. So he asked how come. So I said, time has passed, it's 9 years, and even if you went to the same dentist, he would have done the same thing. So let's compare to TS on the maxillary sinus. If there is a difference, then I think Herman's paper, something you would agree on the trans mucosa neck, one piece type of implant. Then from the external environment to protect the implant, the biological width, they say, is less needed. So shallow placement is okay, but for two-piece platform matching neck, they say you need more width. In other words, you have to go place it more deeper. So if residual bone is less than 2 millimeters, then going really deep is really challenging. So because I used the guide, I confidently could know how much was the residual bone, so I could place it, but I actually wanted to go shallow. Then SS implant would be the one I would opt for. It's a similar situation, less residual bone, and compared to the previous case, I went less deep. So as you can see, there's not much residual bone, but for this case, I place it a bit more shallow. And after 4 months, if you look at the X-ray, in the cortical bone top part, there's lining, and we went with the final prosthesis. So if I may, the SS type on the maxillary sinus, then you could not, fix in the position. So if it becomes unstable, what would you do? You opt for TS, so you remove that implant and opt for TS. That means just placing only SS is sometimes impossible. So you always need to be prepared, right? Well, actually using TS up to anterior and up to front part, I don't really use SS that much. So actually in the clinic, I use 70% TS and posterior very much so. I also have the same kind of concerns rather than SS. Company S implant, sometimes patient wants that. So at that in the beginning, there was no bone level type. So I was really nervous. And the S implant, it's not a screwed type. It's a bit closer to cylinder type. Yes, it's a thread type, but it doesn't really, you don't have a lot of stability. So if it doesn't fix in the place, then you have to remove it, but it's expensive. So I find then company A's implant might be better. If you want, patient wants foreign made, that would be better. And that's why I asked that question. But anyways, within the same company, everything is, given, even the company's drill is also used, and using S implant might be okay. But and also OSSTEM screw type, the SS or TS thread type, as you said, compared to S company, in this case, it's better for gaining primary stability. It's more favorable for that. So recently, like this, when you do the sinus lifting, there's not much residual bone, and actually TS implant, they may say go deep. But if the residual bone is 1 millimeter, so going deep is not easy, so you go shallow. So more recently, in the past, when I do lateral approach, then I didn't really opt for SS, but more recently, I find that even in the lateral approach, when needed, find maybe I should or could go for SS implant. So depending on the case, don't insist on one type of implant, because each implant has its pros and cons, so you need to be just aware of that. And I have one more question. Prosthesis is different, right? Impression taking is different. So within OSSTEM, it has different system. The impression taking process is different. It's the same, but the parts are different. But in my opinion, the biggest weakness of SS is that TS, you have, hex or non-hex fixture, but with the XS, there's no digital component. So in digital area, I cannot grow. So I also asked the OSSTEM's person, non-hex implant, do you have any plans to create skin body? And he said no. So on the digital side, I'm lagging behind. So I believe having both systems, as a surgeon, I didn't think there's much of difference, but having both systems is not easy, right? But do you use both between non-hex and SS? No, between two systems. Oh, you only use TS? Yes, I only use TS. So she said TS is better. Anyways, as I said, if I may add one more, last month at our region, 2 dentists actually had implant by me, and both dentists, when asked which one do you want, they had a different answer because they were dentists. They both said you use a system that's more familiar to you, so I opt for SS. So if somebody said, please use S implant, I think the result will not be good. So I think the product that is most familiar to surgeon is the best product. So another case, similar case, residual bone is about 5 millimeters. So a very similar case. So on the lower part, if there's a bones, then I only go up to 4.5, but on the upper part, there's insufficient bone. And if you want, implant that is short, then 5.0 is something I go a lot with. So anyways, the minimum lifting is what I prefer. So one cast system, I only need elevation and without any bone grafting. So placing like this, I think would be also okay. This might be an approach that our dentist who posed question could use. So it's centered, and if it's SS on the pellet side, buccal side, if it leans, then the prosthesis might look really bad, and there's no way to overcome that. So that's really big weakness. And another thing, really strength of SS is that the vertical moment volume could be reduced if you measure from the screw type. But I don't think this is a big disadvantage. And also horizontal cantilever volume, you could also, reduction of that could also ignore. But as a vertical moment volume compared to TS, yes, there is a reduction. But TS implant, if you know its characteristics and did the screw retightening on regular basis, and if you place on the right position with the right diameter, whatever the product you use, all will be okay. But I think one of the reasons I really like SS is it has excellent retrievability. What do you mean by that? So it's easy to take it out. So internal conical type for TS type, if after placing the implant, after a few years, the prosthesis, if you want to remove it, it's not easy. But for tissue level implant, if there's a contact loss, then you unscrew it, and also external type also, it can be easily removed. So in correcting prosthesis, it's very easy. And after 5 years of use, TS implant type wants to remove it, then I cipher. So prosthesis wise, these are the strengths of SS implant. It has a good retrievability, and that's why I like SS, not because, other things, because both are good, TS or SS. For SS, there is a vertical stop, then that's why that. So for the dentist, I think they prefer that. Some dentists say they only use TS, but depending on cases, I say this might be better with SS, and they're worried about prosthesis. But as a prosthodontist, sometimes if it's wrongly placed, it's better if you had gone with the TS, right? Yes. But anyways, for 3SS was used for restoration, but it's really thick. Maybe it was wrong for me to deliver this, and resin would not solve the problem. But so we removed the prosthesis. But with the unscrewing, it can be removed very easily. Again, good retrievability, so I like SS implant. So removing cement and re-cementing is very simple because there is a vertical stop. So removing the cement and putting it, delivering again, it can be done very cleanly. So I like SS because of that. But I cannot guarantee SS will never break or there's less moment and it's much better. That's not what I'm saying. And in the master course, this is a question I often pose. So of course, to improve, if the direction is wrong, the best option is TS, because the SS cannot guarantee if you place it wrongly in correcting it. And if you have done a bad initial drilling, then you have to correct it and place it again very correctly. If you had used SS, then there's not much room for error there, so you be mindful of that. So SS is really challenging, right? So SS, yes, if you want to, there's less room for error, so you have to use the guide, or you have to check and check and check again. So be it SS or TS, but you have gone on with SS, would compensate the wide width. I think SS is not like the best option. You just have to know how to use it, then be it external or tissue level or internal conical type. I do not believe there will be much difference. And if you do sinus elevation, long-term stability, would it be guaranteed? I think it's okay. So initial stability is bad, and submerging would be not good. So SS would be unfavorable, but it would not, push into the sinus, and it will be much better to retrieve. So residual bone is thin, then you think it's in place, but sometimes it really goes in. You cannot retrieve that, so you have to be careful. And one more thing, for SS, one of the weakness is that gingiva height is set. So I think 2.8 or something, there are 2 levels and only that. I mean, there are, yes, cases where there are other options, but gingiva, if it's really thick or if it's really thin, then TS go a bit deep and secure gingiva height, or abutment, make it longer, so compensate for thick gingiva. That can be you can do with the TS, but with SS, you have to plan everything. You know, you have to use SS type that is well matching with the thick gingiva type. So SS looks much better for beginners, but if you start looking at it, then SS is much better for more skilled dentists. I agree on that too, and that's why I often use TS. But anyways, thank you for your comments on this case. So let's give the conclusions or final answer to the case. Actually, the dentist that posed this question, the sign when he did bone grafting, long-term stability, I don't think you need to be concerned. But what I feel is that now on the crestal side, if you are thinking of GBR, then opt for TS at bone level and do GBR together. And if you are not doing GBR, then with the SS type and tissue level could be an option you can think about. I agree also. TS, SS, I think all are good. In most cases, if you go for TS type, maybe I'm changing my mind, but SS type could be something you could also try out, because SS has its own attractiveness. On the transmucosal side, gingiva height, wide neck becomes wider. So going in, you feel like it's in place. So you feel relieved. And when you look at it, SS going in the wide area, if you have good positioning, then implant shape, I find, would look good in the posterior side. This would be sufficient. So dentists' gut feeling is always correct. So, that's why. So I think SS is something you could also try out. Thank you. Lastly, Dr. Park. Well, in what I said in opening, I think correct myself very well, thanks to these 2 doctors. But my conclusion is this. What is you are used with is the best things. Yes, thank you. At this time, we look at different cases, how to handle the wide width. So I hope it has been helpful to you. And I would like to thank 3 dentists for their excellent comment. Thank you very much. And this was Kim Se-jing again. I will see you next time. Thank you.
수고하셨습니다. 수고하셨습니다.